Dr. SWATHY HARIDAS. Again, we are moving into infective causes, TB or TOXO, solving the diagnostic dilemma.
Hope everyone is having a great KSOS this year. Thank you, Natasha ma'am, for giving this opportunity to be first timers. Okay, so I hereby share my journey with this lady who is a 49-year-old female who came to me on a Saturday evening OP after being referred from elsewhere with a sudden onset diminution of vision in the right eye since 5 days. Left eye, she already has a poor vision since her early childhood. She has 636 parts when she came to me, and the left eye is already counting figure at 5 meter. There is severe nystagmus for her, making my examination very difficult. There is circumcorneal congestion in the right eye with mutton fat keratic precipitates, AC cells 1+, and she is pseudophakic in both eye. Fundus examination, there is grade 4 media haze. There is dense vitritis, and I have very hazy view of disc and macula. Just can make out a white colored lesion in the nasal quadrant, and whether it is retinitis or a choroiditis, I'm not sure. Left eye vitreous is clear, and the fundus is heavily tessellated, tilted disc with a posterior staphyloma, and a large CR atrophic patch inferiorly. Unfortunately, I don't have a fundus picture of her at that point. On system history taking, she gave a history of pets at home, and there is a chronic cough more than 6 months. She's a very poorly built patient looking very malnourished. However, my clinical diagnosis, primary diagnosis is ocular toxoplasmosis for her. My differential was whether it's a panuveitis query tubercular etiology. Since my primary diagnosis is ocular toxoplasma, I started her on oral trimethoprim, sulfamethoxazole twice daily without any oral steroids, and blood investigation were given. And I saw her 1 week later. She is symptomatically much better. AC reaction is practically nil, and vitreous haze has come down 2+. Now the lesion is looking retinitis picture. Blood came out, toxoplasma IgG is strongly positive, more than 650. I'm happy. IgM negative, okay. Manto is negative, wow. But quantiferon gold TB, which I had given, came to be positive. See, the physician inside me aroused. I referred her to district TB center. Chest X-ray came to be normal. She is not expectorating sputum. I forgot to ask whether you have sputum or not. She is having cough. No sputum. So sputum TrueNat could not be done. They have written no evidence of active pulmonary TB and referred her back to me to rule out ocular TB. Okay, so now what to do? My brain told me, do an AC tab and a PCR. Do a vitreous biopsy since the AC is quiet now. But my mind told me there is good clinical response. She is a one-night patient. You are going to do vitreous biopsy with the inherent risk. I went with my mind. I got a second opinion from my senior, and there they saw her after 3 weeks of starting Bactrim DS. This is a picture. The lesion in the right eye, just nasal to the disc, it is looking a very typical retinitis, and it looks healing, but we need to confirm. So what they did was like a wide field OCT was done through the lesion, which typically shows full thickness whitening of the retinal layers, and the choroid is not involved. The retina is involved, the choroid is not involved. And fundus autofluorescence was done, where the lesion shows a hyper-autofluorescent ring-like lesion with a central hyper-reflective. That also indicates that the lesion is towards a healing phase. And she was continued on Bactrim DS alone, and no further interventions were done for her. This is a 2-month follow-up. This is our image. The lesion is very well healing. And this is a 4-month follow-up. She is all good. 612 N8, N10 with -1.5 sphere, and the other eye is counting finger at 5 meter. The lessons that I learned, it's lessons actually. Order appropriate investigations for the patient, and not all battles are won alone. And do no harm to the patient.
Great presentation, Swati. I think you've covered all the lessons that we have learned in that. But can I just ask you, what was the time period between your Manto and your quantiferon?
Simultaneous. Simultaneously I had done.
Okay. What is the rationale behind it?
I don't know.
Nothing. You just did. Yeah, a lot of us do that. Just order everything there. But always remember that if the patients had a manto before, you are injecting the tuberculin antigen, and the quantiferon is detecting that. So you can have a positive quantiferon. Just it will be a very low positive. It won't be very high positive, but a low positive quantiferon is possible if the patient has had a manto recently. I don't think it is applicable in her case, but if there is a time delay between your manto and your quantiferon, you can get a false positive quantiferon. So if you're going to order both, better to do the quantiferon first and then do the manto later when you are when the quantiferon comes either negative or equivocal or something, falsely positive. And ideally, if the patient, now most of us have moved towards quantiferon. If the patient can afford it, better to go, because at least you get a definitive answer. The manto is so difficult to interpret, so you don't get a definitive answer. So if the patient can afford, go for a quantiferon itself. I think nowadays the government hospitals are having some other kind of skin test. It is not a manto. Can anybody tell us about that? It is called something else. It is similar to a manto. It is a skin test, but it is not called the manto apparently. It is called government medical colleges. I have it in. I have a couple of patients who come from Kalamasheri Medical College, and they have. Anybody from Kalamasheri Medical College here? Okay, I can't remember the name of it. It is called a something skin test, a TB skin test, but it is apparently not a manto. So anyway, any skin test is very difficult to interpret, because you know that we are a TB endemic country, and you will get, so only more than 10 millimeter, more than 15 millimeter can you consider as positive in our country. So that is one point. The second point, what she said, is very, very important. Your patient is clinically responding. Irrespective of your lab report, go with your mind and don't go with the lab report. If it is responding, don't have to think of anything else. If it is not responding, then you think of anything else. Or once you stop the treatment, the patient comes back with a recurrence, then you think of further investigation. Otherwise, I know a lot of people who order TOXO. I've seen so many patients who have been ordered TOXO for a non-granulomatous anterior uveitis. TOXO comes back positive. So what? There is nothing of TOXO in the eye, then you don't have to give the patient 6 weeks of Bactrim DS. That is not required. TOXO will not cause a mild non-granulomatous anterior uveitis without any retinal involvement. So always investigate depending on your clinical picture and not depending on like a plethora of, okay, patient has uveitis, let me just order all of this. That is not how it should be done, because it will cause more confusion. The third thing is the OCT. The OCT, always remember that TB is predominantly a choroidal disease, while the TOXO is predominantly a retinal disease. So if you get more retinal involvement than choroid, you're looking at retinitis, and always remember retinitis is almost 90% infective. So you're looking at an infective cause. If it is not TOXO, it can be candida, it can be an endogenous end-off, you're looking at it can be syphilis, you're looking at an infective cause. But if you have choroidal involvement, you're looking at conditions like TB. And very few retinitis causes are non-infective, one of which is Behçet's. Otherwise, generally, all the retinitis are infective retinitis. So your OCT can give you a good clue. Then anything else?
One more point to add is when you order for tuberculin, please mention to inject 2 tuberculin unit only, because that is better for interpreting whether there is any ocular TB present or not, because otherwise they inject 10 TU and most of the people come as positive manto. So please write 2 tuberculin unit. That is the best dose for interpreting ocular TB. And the same as what Madam told, this TOXO IgG and similarly CMV IgG can become positive even in the normal people. So those results have to be interpreted taking the ocular findings also into consideration.
Any questions?
This is a one-night patient now, almost.
Yes.
Yes.
He came with a sudden loss of vision, and somebody referred.
Oh.
It's very dire to wait for 1 week, giving only quatrimoxole and review after 1 week.
But the clinical picture did look like TOXO. There is
That is
vitritis.
her confidence. That is what.
I think all of us are
Luckily
confident
for
when
me,
it
she
comes.
improved. There is someone above us.
Okay, thank you, Swati.